Now we are live. Hello, lovely Dr. GInni Mansberg, author of Save Your Brain, that we are discussing today, all the way from the Gold Coast, where you've just had another product launch, which is very exciting. So
It is, yes. I wear so many hats. So I'm talking to you tonight with my Save Your Brain hat on, but I'm in the Gold Coast, which I don't know how many Aussies are joining us today or tonight, Australian time, but it's an it's a beautiful place. Gold Coast is a beautiful place. Perhaps not where I am right now, which is Surfers Paradise, right in the heart of it.
well, there you go. And I hope the weather there is nice because it normally is all.
Magnificent.
There you go. Good. Now, we have much to discuss here on brains, and especially since that Danish study that came out a little while ago. But before we get to that, the interesting thing about dementia and Alzheimer's and the various different forms is that apparently 40% of them, as you say in your book or thereabouts, could be prevented or delayed. So the question is, how do we do this? Should we start then by running through what the major risk factors are and how we can deal with those?
Yeah, because the number's actually up to 48% that could be prevented. But I think your passion and mine, Fee, is midlife and particularly midlife women. And we've got to remember that dementia is a women's problem. Twice as many women get dementia as men. And yes, we do live longer. So, of course, we've just got more opportunities to get it. But it is the biggest cause of death of women in Australia and the biggest cause of death in Australia and disability all round, both men and women. And it's just a really major thing. But what I was really passionate about is the fact that what you need to do to protect your brain starts now in midlife. Because it's not that if you sort of hit 70, 75 and go, oh, wow, I have not just completely neglected my brain, that all bets are off. Sorry, it's too late. That ship has sailed. There is always, always, always good reasons to try and protect your brain. But the biggest bang from your buck comes from starting things now. And the reason why I put it all into a book, because it's like a massive all-you-can-eat buffet. And I don't expect everybody to do everything for their brains. We can't. We're busy. We are midlife women. This is the busiest time of our lives: career, family, kids, elderly parents, all the rest of it. But everything that you do can help. And it's everything from making sure your hearing is okay, because hearing in midlife is catastrophic. If you have deafness in midlife, it's catastrophic for your risk of dementia. Same thing with not sleeping enough. The difference between sleeping less than 6 hours and getting 7 hours at night is huge. It dramatically increases your risk. Having midlife depression, having
And
midlife high blood pressure.
through them all that quickly. Just let me take you back to the
Yeah,
hearing for a second. Now, hearing is
yeah.
an interesting one, like the dementia and HRT one. What do we know about what causes hearing loss? And because I mean, first of all, the hearing loss in the beginning, I'm thinking, well, it must be okay because you become isolated and you're not hearing things, and that's isolation and being lonely is a risk factor. But it turns out it's the actual hearing loss itself, they believe, that is the risk. So what's going on when we lose hearing and how can we prevent that?
So there are possibly things happening inside your brain that causes the loss of hearing that is also infecting your brain globally. So it's not just damaging the part of your brain that deals with hearing. It is possibly that there's no point in going out and having a conversation anymore, because the minute you go out and are with any more than two people, you can't hear anything and you get a bit lost. So you start avoiding going out. You just watch the TV and turn it up, crank it up really loud. We're not 100% sure. But what I can tell you is that if you particularly start to lose your hearing in midlife, you have a dramatically increased risk of developing dementia. But if you actually get a hearing aid, so if you bother to go and get your hearing tested, get a hearing aid, wear the hearing aid, because a lot of people who get them don't actually wear them, we can actually slow or even prevent that progression to dementia. And it's so simple. Like, it's just something that we can all do. And I think it's really, we owe that to our sisters. Like, if we've got a girlfriend who we think is hard of hearing, we got to go tell her, like, go get your hearing check, love, because we could be saving her brain. And we're not good at picking it for ourselves. It's our partners who'll go, oh my God, that podcast is so loud. What's wrong with your ears? And we need to be telling each other, keeping each other in check, and going and getting it tested, because it's pretty simple. And you don't need to wear a hearing aid all the time, but certainly in public, or where you go out to a restaurant or you're going to work, that might really, really help.
The other thing too about that is there's two things going on with hearing loss. The ear does have estrogen receptors, and there are blood flow issues. So what do we know about HRT and hearing loss? It seems that, like with dementia, there's a lot of conflicting studies.
So I think we're only just starting to look at this. So, I mean, I remember when you and I were in London together and speaking to Vikram Talokana, and he was sort of saying that when he first started, managing patients with dementia, I think he said there were sort of 5 symptoms of dementia. And now the last time he looked, there were 43, including things like dry mouth, dry eye, dental problems that really peak, gum disease, all sorts of things that we didn't know about before, and we're just starting to work it out. And then again, some studies say, yes, there is a connection, and some studies say, no, there's not. So I think what I would say is, if you believe that there is a link and you've gone through menopause and all of a sudden your hearing has just gone through a leg down, there is very possibly a link. The so what of that is not yet known, because what we don't know is, does going on something like a whole global hormone replacement therapy where you take, let's say a patch or a gel and a tablet at night, does that help your hearing? We don't really know that. What we do know right now is that a hearing aid will definitely help your hearing, and it will definitely stop you, because we've got good studies that will tell us that having a hearing aid will definitely help prevent dementia.
Yeah, we need so much more research on that one, don't we? I mean, we really need to be looking into the blood flow. We need to be looking into the hormones and all those sorts of things that that affect that kind of area. The other one that you started mentioning there before I stopped you was depression. Now, this is one that we all have is it hormone related? Is it not hormone related? Is it actual clinical depression that is the cause, or hormonal related, or what do we know about it? What do we know about depression and dementia?
So depression in midlife increases your risk of dementia in later life by anywhere between 2 and 5-fold, depending on the studies. Now, that is a massive increase in risk. And the tragedy for women is that women are particularly prone to having both anxiety and depression in midlife. And I think there is a very well-justified focus from our health system about the postnatal period. And we definitely focus on women who've just delivered a baby and make sure that she's having the Edinburgh postnatal depression screen, and she gets it done by a nurse who visits her at home, and every doctor who sees her screens and screens and screens, and she gets access to lots of psychology visits. And the problem is that's not the peak risk time in a woman's life. In fact, it is midlife. So it's between 45 and 55 where 1 in 3 women will end up with a mood disorder, and it's the peak time for suicide. And we don't take that as a society seriously at all. And particularly now that we know, research has shown us that that in itself predisposes you to a future risk of dementia, and the cost to society of that dementia. I can't believe that the government is not putting more dollars into researching this and more money into treating this, because the treatment is different. A midlife woman is treated differently if she has depression than if she has it at 30 or even 70, because we know that so often it is hormonal. We do need to look at this from a hormonal perspective. And I know we're going to talk about that relationship between hormone replacement therapy and dementia later on, but given that we are so often saying the first cab off the rank should be actually to fix her hormonally rather than just pulling out a script for an antidepressant medication. And that's not to say she won't end up on an antidepressant medication. It's definitely there as an option as well to augment it. But we should not be going first to an antidepressant medication. Well, that's really relevant. So we need to be raising awareness about the risk at this time, and also validating a woman's feeling that this is hormonal. It probably is. If she says it is, it probably is. Let's listen to her. And let's get her treatment that is evidence-based. In other words, that we treat her hormonally first instead of just pulling out a script off the pad for something that works for a 23-year-old man. It's probably not going to work for her.
Yes, good point. Do we know what the mechanism is between the depression and the link with dementia?
Look, we don't for sure, because a lot of our studies, and this is why you're doing, the Menopause Research Fund, because there's so much of this where we're tangentially putting things together. But we now do have better scans that we didn't have when you and I were younger, Fee, but we now have functional MRI scans. We also have PET scans. These things are expensive, and they tend to sit mostly in universities. So for anyone who's listening to us thinking, oh, I'd love to have one of those scans, they're not easy to get. But what we do know is that depression is a brain shrinking disease. And what you can think of for treatment of, particularly for depression, is you can think of things that treat your depression as brain expanding, brain growing disease. But where you particularly see that shrinkage is in the hippocampus, the amygdala, the kind of parts of the brain that control your executive function and also your intelligence and also your memory, the sorts of things that we really see affected by dementia. So it's probably about literally the loss of neurons in those really key critical areas of your brain.
Wow. Yeah, it's a kind of, because you don't think of these sorts of things really necessarily being related, do you? Other things that are modifiable as well. I guess one of the most important things, especially for midlife women, is high blood pressure. Do we take that seriously enough when we're controlling it? And this is another thing. I noticed in the book you were saying that in Australia now they were really trying to get blood pressures down around 120. Here it's still 140 for the systolic. Are we not taking blood pressure coming down seriously enough?
So it depends on what we're trying to achieve by lowering the blood pressure. If you can get your blood pressure down to a 140 systolic, so just for everybody who's listening to us, there are two numbers in your blood pressure. It's normally expressed as X over Y. So the top number is systolic. So let's say we're aiming for 120 over 90, which is diastolic. The top number represents the pressure, the literal pressure inside your arteries when the heart is contracting, and that's over the literal pressure inside your arteries when the heart's relaxed. So it pumps continuously, and that's what those two numbers are. And when I was at medical school, we used to really focus on that bottom number, and my patients are still really worried about the bottom number because of the theory about, oh, well, if your heart is relaxed and the pressure is really high, that must mean you have really stiffened arteries. Except for study after study after study has shown that your prognosis, everything is to do with that top number, which is counterintuitive, but that is exactly right. The US actually brought down their targets for that top number quite a long time ago, and we call that the New York Heart Association. That's their kind of peak body of cardiologists. We in Australia and the UK have been a little bit slower to do that, and that's really been around if you're trying to achieve a reduction in the risk of stroke and heart attack, or what we're talking about tonight is dementia. And we now have massive trials, and we are talking prospective, which means they're forward-looking trials of tens of thousands of people that to show that if we could bring your systolic blood pressure down to a top of 120 maximum, we could prevent up to 30% and 30% lower risk of dementia. That is really big. So if you're going to lower your blood pressure by taking a medication, don't stop at 140 because that might reduce your risk of a heart attack. Let's get it down further, and for free, we'll throw in protection of your kidneys. What I did want to tell everybody is your blood pressure doesn't sit at that one spot all day. It sort of sits between a band. So sometimes it's the top of the band, sometimes it's the bottom of the band. Now, if we're trying to aim for always that top number being 120 maximum, sometimes it's going to be really low. And the symptoms of low blood pressure are feeling a little bit woozy when you stand up or feeling a little bit lightheaded. The trade-off with that is that we're protecting your brain. But if you never ever want to feel like that, we're going to have to let your blood pressure be a little bit higher. We certainly do that for people who are elderly because their risk of falls could kill them. So we definitely tolerate much higher blood pressure for elderly people who are what we call falls risks. But for you and I, who are in our 50s or women in their 40s and 60s, we want your blood pressure lower to prevent dementia. And I think all of us want to prevent dementia, almost more than we want to prevent a heart attack. So I think it is worth trying to get it down. By the way, those numbers in terms of that 30% reduction is only for women in midlife. This is the sad thing. By the time you're in your 60s, late 60s and early 70s, of course, we will lower your risk of, definitely, we want to lower your risk of progressing if you have already started on the road to dementia. What we know is that only about 60% of people who ever get what we call mild cognitive impairment, which is the first bus stop on the way to destination dementia, only 60% of people actually ever end up with dementia. And everything reduces risk of getting dementia also reduces your risk of moving from mild cognitive impairment to dementia. It's just the quantum of reduction of risk is much lower as you get older. Whereas what we do now in our 50s is unbelievable. Really, really big reductions in risk.
You mentioned stroke there, and in the book it says if you've had a stroke, you've got a 60% higher chance, I think, from memory, if my memory serves me right, of going on to develop dementia. So the blood pressure is also important from that point of view as well, isn't it?
Yeah, absolutely. And we know that stroke becomes what we call bidirectional. So people who are at risk of dementia get more strokes, and people who get more strokes get more dementia. And then it just becomes a vicious cycle. We know that the biggest risk for stroke, apart from high cholesterol and having diabetes and being a smoker, and yes, we want to reduce all of that risk, but it is actually blood pressure, which is actually your highest risk. You can tolerate slightly higher blood pressure and still be okay from a stroke perspective. Still not that great when it comes to dementia. We want to get those numbers lower.
So how do we get those numbers lower? What can we do to bring our blood pressure down?
So it might just be a lifestyle thing. So you might just say, look, I'm going to reduce the amount of salt. And salt is not what you think. It's not bringing your broccoli and your carrots to the table and sprinkling some salt on it. That's totally fine. What we really don't want you to have is packaged foods, because that is laden with salt. So be careful of anything that's packaged. We also know that from a study called, it was the DASH trial, so the diet for high blood pressure, which they looked at having lower sodium, so it's in packaged food, and higher potassium. Just think fruit and veggies, that's loaded with potassium, but also higher calcium, so higher amounts of sort of calcium-rich foods, dairy, soy, that sort of thing. That seemed to really lower your risk of getting both heart attack and stroke, but also now we've got really good data for preventing dementia as well. So it's a good diet. If you want to have a look up the DASH diet, DASH, it's a good diet. I don't think we need to split hairs. If what you're sort of saying is, oh, the DASH diet has, maybe the Mediterranean diet has more cruciferous vegetables and the DASH diet has more green leafy vegetables, I think if you're splitting hairs over that, I wouldn't worry. I think if you're going to McDonald's, go and read up on any diet. I don't really care which one it is.
All right, good point. Question here from Lana asking, if you have a history of stroke and heart disease, can you have HRT?
Oh, that is such a great question. So, yes, that is not a contraindication at all. What we do like to do is to make sure that your blood pressure is under control, so that your doctor will measure your blood pressure before initiating that. And if your blood pressure is high, and a lot of patients say to me, oh, look, I was just running around today, I can't prescribe it to you until we've got it down. But if you have got it down because you're on a medication, for example, no problem. What we tend to do is to go with a transdermal route for your estrogen rather than a tablet. So transdermal means either a patch or a gel or a spray, one of those kinds of methods of getting estrogen into your body, because it has a lower or a zero increased risk of clotting, any clotting problems. And of course, clotting can be clotting in the legs, but also, and that can flick off into your lungs, but also clotting that causes stroke. So what we tend to do is just go, look, that wouldn't be for you. That wouldn't be my first choice. You can totally have it once we've got your blood pressure down. Then we can stick you on a patch and a tablet. We will talk about the timing hypothesis, because we need to make sure that we're starting you on it as close to the date of menopause as possible, because the later we leave it, the effect of having had no estrogen in your body starts to stiffen your arteries. And at that point, estrogen flips from being incredibly cardioprotective to actually bad for your heart and increases your risk. So there's just, everything is about timing, but as long as you haven't had that, Lana, for too long, as long as you haven't been in menopause for too long, yeah, you can still have hormone replacement therapy, no problem.
All right. Other pre-existing conditions that people might need to think about, diabetes, that's one of them. What's the relationship between diabetes and the brain?
So we always say, as a general rule, that what is bad for your heart is bad for your brain, and diabetes is bad for your heart. Having said all of which, well-controlled diabetes, so in other words, if your sugars are what we call at target and your doctor keeps going, your sugars are fantastic. And I have patients who technically are not even in a diabetic range anymore. Their blood sugars are so good. We still continue to call them diabetic and we still treat them, but their risk is actually not particularly high. It's poor diabetic control that is linked to every single risk, whether it's losing a foot or having kidney disease or having eye disease, because it's the leading cause of blindness at the moment after macular degeneration. With all of those things, it's all about having poor sugar control. So if anybody has been diagnosed with diabetes, please, that is not a death sentence. It just means, you know what, you've really got to take your health seriously. You've really got to get on that diet. You do need to remember to take your tablets, but you can have the same life expectancy as everybody else. And similarly with your dementia risk, if it's well controlled and you've got everything else under control, you don't need to be really afraid. I will say, though, that there is emerging evidence that pre-diabetes, so that's a blood sugar level that is not high enough to actually be called diabetes, but not normal either, and there's quite a big space there. There is an increased risk of diabetes for people with pre-diabetes. So again, it's just a matter of saying, I can't slack off anymore. I'm going to have to take my diet seriously. I'm going to need to do some exercise.
Right. Well, let's exercise. I note that you say in the book that you are a aspirational exerciser.
Yes,
What
it's
is
at best.
what is the evidence when it comes to exercise for decreasing our risk of dementia?
It's not much. It's actually really interesting. There are a lot of doctors who sort of say, oh, it's the first and most important thing you should do. And we do have evidence that it's sort of people who exercise regularly definitely have a lower risk of having heart disease. It's definitely good for depression. You definitely sleep better. And all of those things like depression and lack of sleep and having heart disease are all independent risk factors for dementia. So tangentially, we should know that doing exercise is really, really good for the brain. But a recent study just came out, I think a week and a half ago, of midlife men and women, showing that at the start of the study, so I think it was a British study and it actually went for about 15 years. At the start of the study, the exercisers of the group did much better in a whole range of short-term brain performance tests. Now, these were not, it's nothing to do with dementia. These are not tests for dementia. These were just recall, how many animals can you name in a minute? How many of these words can you remember? Over the time of the study, what they found was all that mattered in terms of decline was sleep. It didn't matter whether you continued to exercise or gave up your exercise. What really mattered for whether you continued to do well on those tests or whether you got worse was how much sleep you had. The evidence for exercise is not awesome. Having said all of which, no doctor ever is going to tell you not to exercise because it's just really good for you. And I need to do what I say and not what I do.
I'm the biggest one for that one. But I guess even if there isn't necessarily direct evidence for exercise and dementia, it can prevent or improve your diabetes. It can, it does so many other sorts of things for you, plus keeping your weight under control, which is another sort of risk factor for everything.
Yeah, obesity. Yep.
So let's tackle sleep, shall we? Now, you've got a whole chapter in the book on sleep. Why is sleep so important and what type of sleep?
So we've got a lot of theories about what sleep does. Your brain is very, very metabolically active. So it sort of makes up I think it's about 10% of your body's weight, but actually uses like 15 to 20% of your body's glucose on any day. And as it metabolizes things, it puts a lot of refuse, a lot of garbage out that goes and sits into a little fluid system that kind of surrounds the brain that we call the glymphatic system. That system that kind of rinses your brain and gets rid of the rubbish and ensures that your brain doesn't need to go into overdrive of inflammation and start trying to overly clean up because your brain is just not great at cleaning stuff up. It's designed to keep out bugs from a million years ago. It hasn't really developed that well to adapt to a modern lifestyle. So it will tend to go absolutely crazy thinking that everything is tuberculosis of the brain, and it will tend to kill off a lot of brain cells at the same time. The glymphatic system is only active when you're asleep. It is completely dormant and does nothing when you're awake. And that's probably, they think, a very big part of what happens when you're asleep and why sleep is so critical. And what we know is that getting less than 6 hours of sleep a night, it seems to sort of really significantly increase your risk of dementia compared to people who have 7 or more hours of sleep by about 2 to 5-fold increased risk. So that sleep in midlife is really, really, really critical for just repairing your brain and just doing some general maintenance on your brain. In terms of what kind of sleep, the biggest concern that I have is the underdiagnosis of what we call obstructive sleep apnea, and particularly that will happen for single women. So obstructive sleep apnea is when the upper airways around your neck collapse when you sleep at night. And if you have a partner, they will know because you'll snore. Now, a lot of our partners, if they're men, are snoring themselves and they're so busy snoring they don't hear us snore, where a lot of my patients are single. I mean, this is the peak time for divorce and separation. A lot of my patients who decide not to divorce for whatever reason, the kids start moving out and they now have separate bedrooms and no one's heard them sleep for a very, very, very long time and they don't know. But if you are waking up with a headache, if you are waking up tired, then there's a very good chance that you have sleep apnea. And it's probably worth going and getting a test because sleep apnea is an independent risk factor for dementia, as it is for heart disease and stroke. And so if you are thinking that you're not waking up refreshed, you wake up with a headache, you wake up and you're immediately tired, then I think it's worthwhile asking somebody, if you do live with them in the same room, do I snore? And if you do, go and get a test. If you don't, it might be worth going to your doctor and getting a test as well for sleep apnea. In terms of whether it's a nap or nighttime sleep, we think it's nighttime sleep because of the way the sleep architecture should move, that you should generally be sleeping at night. If you're going to do a nap, I'd sort of keep it to a nana nap of about 20 minutes or less and not do more than that. That really interferes with your sleep.
Okay. The other interesting about the snoring, I remember as you know, and some other people who listen to me regularly when we talk about brains knows, my mother had early onset Alzheimer's, and she was diagnosed in her mid-50s, dead by 68. And my God, did the woman snore. I mean, we are talking windows shaking snoring. I remember she came to visit me in London at one stage, and this is early on. It was before she was diagnosed, but this is when we realised there was something significantly wrong, because she was a great royalist. She'd gone with Dad to Kensington Palace for a day out, and when I came home from work, I asked her, "So how was the visit to Kensington Palace?" And she said, "What visit?" She just had absolutely zero recollection that she had spent the whole afternoon at Kensington Palace. And then that night, literally, I have never heard snoring like it. I remember I was in the bedroom and I thought, that's got to be Dad. And I thought, I cannot, no woman could snore like this. And I got up to go out and shake him. And I got out there and I saw Dad sitting with his eyes wide open, and it was Mum. And literally it was enough to shake the windows. The other thing that she had that was very, she only slept probably no more than 4 hours a night. And she had horrendous vasomotor symptoms. Her hot flashes were melt you. So how do all of those things come together then? Because I mean, many menopausal women are going to be saying, I don't sleep at night. I'm constantly up. I'm sweating to death. How does the vasomotor and the lack of sleep come together, and what can we do to fix that so we do get at least 6 or so hours worth of sleep?
There's a lot to unpack in that question. So there has been a very strong link that was established a very long time ago, that vasomotor symptoms, which are your hot flushes and your night sweats, are a significant predictor of future cardiovascular disease, so heart attacks and strokes. But now there's an increased recognition that it's a link to dementia as well, so probably through the same mechanisms. How? We are not sure, and we think it's far more complex than just the hot flushes keeping people up at night. What we don't know is if treating those women who have very hot flushes with a hormone replacement therapy reduces their risk of dementia. And I'll tell you why. Because the current forms of hormone replacement therapy that you would say are safest have not been around long enough for the women who have started them. So mostly who are sort of Gen Xers, let's say late 50s now. They're not really old enough for us to know the risk of dementia later on. So we've only got studies when women were using forms of HRT that would be considered today less safe and less effective as well. So it is a little complicated. So in terms of what can we do to fix your sleep? Because I think that is really important. And I think that when we look at particularly women in menopause transition, which is also sometimes called perimenopause, insomnia is a massive, massive, massive issue, and it extends way beyond whether or not you're having hot flushes. The insomnia often starts for women in their 40s when they're in that, what we call straw -2. They're actually quite far from menopause proper. In fact, their estrogen might even be high, not low, and yet they're still not sleeping, but their progesterone levels are very, very low. What we don't have evidence for is giving women progesterone-only HRT in that straw -2 stage. A lot of doctors are still doing it, but we don't have really good evidence that that is an effective thing to do and that will help prevent insomnia, or that it'll help prevent mental health conditions, which are often starting in that early menopause transition stage. How do we know that you're in that early menopause transition stage? It can be really hard to tell, and there is no point doing a blood test, because what your blood tests say one day will be completely different the next day, completely different a week later. It is completely unhelpful. But if you just think about your age, and I just do need to say that certainly the Australian statistics are that 14% of women will go into menopause proper before the age of 45, and 4% will go into menopause proper before the age of 40. And these are women that are completely neglected by our system. Like, we don't help women in their 20s through menopause at all, and it's devastating for them. So it's not always an age thing, but if you are in your 40s and you're starting to think, I'm feeling anxious, I am not sleeping, and my period is slightly irregular. So when I mean slightly, it's not I haven't had it for 3 months. I mean, it's either 7 days late or 7 days early. So I often hear my patients going, I'm getting a period every 2 weeks and it's really, really heavy. That is a perimenopause thing. Or I'm going every 5 or 6 weeks. That is a perimenopause thing as well. You will consistently find out that you've lost your estrogen. Well, a lot of women will, because 75% of women will get the hot flushes. Even more than that, occasionally, particularly Asian British women and Asian Australians will get aches and pains. And we know that that responds very well to hormone replacement therapy. We get that from low estrogen, and that comes from the later stages of perimenopause. So you don't tend to get that as much in the early, although you can, because your estrogen's up and down like a yo-yo in the first stage of perimenopause. So it can be really hard to tell. In terms of how to get that sleep back, because it is really, really difficult, I don't want to talk about drugs, because I think everybody here who's on this call can go to their doctor and get themselves some drugs. It would not be my first port of call. We know that exercise is really important, but I did want to say something about circadian rhythm management, because the research in this space is so fascinating. I am like blown away. So we used to say to people, sleep hygiene, which was kind of modified circadian rhythm management, meant that you need to get your brain ready to go to sleep, dim the lights, have a nice warm bath, go to bed the same time every night, get up the same time every morning. We now know that it is so much more than that. And if what we really want you to do is to have your meals at the same time every day, have your shower at the same time every day, go to work or get up and get on the bus or get on the tube at the same time every day. It's those markers along the way on your day that is critical for managing your sleep. And there was a fantastic study that I talked about in Save Your Brain about an aged care facility actually in Israel, where they randomized half the people to do like an exercise class and the other half just to go and have one lecture about circadian rhythm management, where they were told, just advised, go and have your breakfast at the same time every day, your lunch at the same time every day, make your dinner at the same time every day. We don't care whether you have a shower in the morning or night, just make sure it is always the same time every day. That seems to actually have a significant impact on your gut microbiome. This is a big reason why, as you move over, go overseas and travel and go out of your time zone, your guts get stuffed up and so does your sleep. It seems to be a big part of the gut microbiome from having been that time on a plane. And that's very big for Australians because we've got long trips everywhere. But that's a really big part of it. Those people in Israel who got just that 1 hour lecture about circadian rhythm management had 1 hour of extra sleep, but significantly improved sleep quality. So that is, 1 hour is a game changer. We have just heard that having 6 hours or less is terrible for your brain versus 7 hours or more. 1 hour, that is a game changer. And it was just from managing your circadian rhythm every single day. Of course, usual stuff. Don't fight just before bed. Say we'll take this offline, we'll do it tomorrow morning. I wouldn't watch a scary movie, get your heart rate up. I just try and, relax in the evening, before bed. Try and, if you are really full of worries and full of stress, and a lot of us are at this age, we've got a lot going on, it might be worth going and getting some help independently from your GP and maybe a psychologist. But that would be, the circadian rhythm management is my biggest tip, 1 to 20 on managing your sleep.
Interesting. You said you weren't going to go to medicines, but just let me throw this at you because it's slightly controversial. I was listening to a really interesting podcast yesterday about the Menopause Society, which was called the North American Menopause Society until recently, and now calling itself the Menopause Society, yes. And the guidelines that they just put out the other day about various different types of things that are good for vasomotor symptoms and those kinds of things. Now, if your vasomotor symptoms aren't well controlled and you're on HRT, do you think it's worth adding something else then, like an SSRI or something like that, an antidepressant in a low dose, just so you can actually get through the night without turning into a melted pile of sweat?
Yeah, so I think those Menopause Society guidelines were interesting for me, particularly in the fact that the 2015 guidelines that they just revised now did have a number of herbal therapies that they thought were quite helpful, and now they've taken them all off the list and said nothing works. So I thought that was very interesting. In terms of what works for vasomotor symptoms, we do have pretty good evidence for quite a few things, many of which do not have a lot of side effects. So I think what's most interesting that's now available in the UK, not yet in Australia, is the neurokinin 3 inhibitors. So we actually have worked out exactly what causes hot flushes, which is something that we did not know when I wrote the M word. It was just a very new and evolving science. But in fact, we now know exactly what causes it, and we can switch off with quite few side effects your vasomotor symptoms. In terms of other medications that can help, we know that HRT is around 96% effective for vasomotor symptoms. And what I like about HRT is the conversation for too long in menopause used to be just about hot flushes. That was very unhelpful to women because it allowed us to focus on one particular symptom and fans and just wearing a cooler outfit and wearing a cardigan instead of a jumper. And it really it failed to wrap up the itchy skin and the mental health conditions and the insomnia and that confidence cliff that so many women fall off and the aches and pains and things that we did not validate. And the thing that about hormone replacement therapy is it is a bit of a one size fits all that will sort of help you with a whole lot of things, including your mental health, including your skin, including, those aches and pains. And there's not enough attention paid to that, because I think if it was just hot flushes, then you might not necessarily be wanting to do HRT. So it is just something that I did want to say. In terms of which of the medications that we would use, there's still a lot of stigma about being on an antidepressant medication. So some women are not happy with it, but some of them, they're really only sort of 65 to 75% effective. The one that I probably like the most is oxybutynin. So oxybutynin is used for stress incontinence. So there are two types of incontinence, or kind of three, because most people have a bit of both. The stress incontinence is actually when you jump up and down on a trampoline and a little bit of wee comes out, or you run for the bus and a little bit of wee comes out. That's from a weak pelvic floor, and actually pelvic physio is amazeballs for that, and a lot of women have that. The other type is urge incontinence, and that has nothing to do with pelvic floor strength, and a lot of women have that who have never had a child. And that is when you didn't realize you needed to do a wee, you stand up and all of a sudden you've just weed, or you get home and you're putting the key in the door and you just can't get there quick enough. Is almost a brain sort of relationship. It is much worse if you're constipated, and constipation is much worse in older women, we know. It seems to be worse with caffeine and worse with fizzy drinks. Any fizzy drinks, even if it's just fizzy water, will make urge incontinence worse. But we do have medications that actually stop the bladder from overly contracting, one of which is oxybutynin. It needs to be taken 1-2 a day. Some people get worse constipation, that is a problem, and some people get a very dry mouth. And if you're prone to dry mouth, this might not be for you. But it's around 85% effective for women who have hot flushes. And we can also get rid of your urge incontinence at the same time. So when I'm talking to one of my patients to say, what are we going to add in for you as this extra thing? What I normally try and ask them is what's most important for you. If you have depression, then let's add an antidepressant. If you have urge incontinence, let's add oxybutynin in. If you have nerve pain from sciatica, then we can use, pregabalin, which is a nerve pain reducer. None of them are as effective as the oxybutynin, which is sort of 85% effective, but they're all not bad. But I like to get a bit more bang for my buck than just saying it's just all about your hot flushes. Let's see what else we can hit you with.
Yeah. You mentioned quality of sleep before, and of course, one thing that affects quality of sleep is alcohol. What do we know about alcohol and dementia? Is it the root of all evil, or is there a glimmer of hope for a glass of red wine?
I think there is a glimmer of hope for the glass of red wine. So a glass of red wine a night is a part of the Mediterranean diet. And they think that it's some of the antioxidants. It could just be, as we always say about the Mediterranean diet, people don't tend to sit there on their own and have a Mediterranean salad and a glass of red wine. In the Mediterranean countries, it's communal dining, often with family and friends. You're often outdoors. There's a lot more to it than just the actual food on your plate. Having said all of which, it is part of the Mediterranean diet. And there have been a very large number of studies that have shown a small amount of alcohol might be protective of your brain. But it's like it has this J curve. If you can picture the letter J, zero alcohol is actually worse for you in terms of dementia than a tiny bit, which is sort of 1 to 2 glasses a night. We say generally 10 standard drinks a week. And then any more than that, the steep curve of the letter J, it just keeps going up. And so if you were looking just to protect your brain, we'd probably say, 10 drinks a week. So that's just slightly more than 1 a night. And yet does look like red wine is the bomb. It's fantastic. But if you just don't like red wine, I think you could probably be okay. There are antioxidants in white wine. There are antioxidants in beer. If that's what you want to have, that's fine.
Okie dokie, good to know. Gum disease. Now, this is one we don't often think about when we're thinking about brains. Nobody really thinks about their teeth. What do we know about why is gum disease an issue?
We don't know, except for the bacteria that are involved in gingivitis, which is the inflammation of your gums, which it's really worth getting that fixed because your teeth become quite loose and are very prone. You don't need to do much to have your teeth fall out. And I think none of us want to be toothless crones as we get older. So it is worth looking after your teeth. But the bacteria that cause gingivitis have actually been found inside the plaques of Alzheimer's disease. Now, that is a mind-boggling thing because you think, how did it get there? We don't know for sure that these bacteria have traveled from your gum to your brain and actually caused Alzheimer's disease. We don't know that. It could just be because we've also found that gingivitis is linked to heart disease because it just generally increases inflammation in the body. Your body is trying so hard to mount an immune defense against the bugs that are sitting on your gums that generally there are more inflammatory markers, and we know inflammation in the brain is bad when it goes out of control, and it does tend to do that. So we're not really sure, but we do know also that people who, I guess, spend money on going to the dentist because it's not cheap. If you go to the dentist twice a year, you have a lower risk of a whole raft of diseases, and dementia is one of them, and so is heart disease. So for anybody who has not got around to seeing the dentist, tomorrow, or you're not going to do it today because it's Sunday, but tomorrow, let's just get up and book that appointment.
Yeah. And obviously, I guess, you can do a lot yourself at home, making sure you do actually brush your teeth, that you floss regularly, all of those sorts of things to protect your gums. Supplements. This is the other thing there. I mean, as you know, the market is awash with supplements for absolutely everything, including brain-saving supplements. What, out of the experts that you spoke to, many of them, what was their opinion on the supplements? Where did that fall down?
So I wanted to speak to experts from around the world about what really works to prevent dementia or different things about dementia because I'm a GP, I'm not a brain expert. So I kind of put my journalist hat on and wanted to interview the experts. Very few were taking brain-specific supplements. I did speak to, I guess, some holistic or one integrative neurologist and one researcher who's a scientist who is taking supplements a list of supplements as long as your arm. But that was 2 out of 22. And the other 20 were not taking anything other than for general health or because they've been found to be deficient. So a lot of the North Americans and Europeans were taking vitamin D because they've been diagnosed specifically with vitamin D deficiency, which again, while the evidence is still lacking because this is a relatively new concept, we've only recently been able to measure vitamin D. So we don't have long-term trials about vitamin D supplements and dementia. If you have a known deficiency, it just kind of makes sense to take the supplements, but we can't promise you that it will actually deliver you the health benefits that you want. But, on a wing and a prayer, a lot of doctors are taking them, and a lot of them that I spoke to are taking them. But there are a lot of specific supplements that are marketed for the brain, and none have been found to work. Most of them have only got a couple of studies in either petri dishes or rats and mice. And while rats and mice are scarily genetically close to people, and actually it is a really good place to start with your very first trials of any medication, the vast majority of things that work in rats and mice will actually fall over and never make it to a marketable medication because they're not that similar. And there are a lot of problems that you encounter when you put these things into humans. There are a lot of interactions with your food, with the rest of your body, with your other medications. We are not there yet with any supplement whatsoever for your brain. We are there with a healthy diet, though. So if you are thinking, oh, I would like to get all of these things in supplement form, you could get it from your food and for free. We will throw in a healthier gut, less cancer, less, osteoporosis, less heart disease, less strokes, less depression. Depression is very diet dependent as well, and probably better sleep and probably better skin and everything else. So it's like a real bargain thing that you could do for yourself, and you could save all your money on the expensive supplements that probably don't work.
Good point. What about brain games?
Oh, that was really interesting. So my iPad tells me all the time that there is a game that I should download because my neurologist is begging me to download it because it would save my brain. So out of the 22 experts that I spoke to, none of them were doing brain training games, is probably, I mean, we do have a few studies that shows you play game X, which aims to improve, this particular tool, whether it's, remembering a number of names in a certain amount of time. You can improve that by doing that game, but that doesn't tell you you're going to actually prevent dementia. And in fact, what every single expert that I spoke to was saying is one of the best things that you can do for your brain is just get out and meet people and talk to people. Let's not get snotty. You don't need to learn Russian poetry. You don't need to learn, violin concertos. I don't care if you work in a supermarket or at a bus stop. Every bit of work that you do involves you interacting with somebody. It involves you keeping to a circadian rhythm every single day, unless you're doing shift work, which is a problem for nurses. But pretty much, if you're getting up every day and going and interacting with people, that is so good for your brain. If you think when you go into, maybe a party and there's, 80 people there, and you need to now scan every face and find the people that you know, and then go up to them and listen to what they're saying and work out a good time to sort of interrupt the conversation, and then participate in a conversation with a number of different people, read all their body language, listen to what they're saying, process a number of different ideas, read between the lines, gauge the room. That is really, really hard work for your brain. That is probably the best thing that you can do for your brain. And I would much rather you do that than sit at home alone on an iPad and play another brain training game that we pretty much know is not going to work.
Actually, it was one of the interesting things in here when you were talking to a lot of the people, that most of them said they intended to keep working for as long as they humanly could, actually, and not just because of the mental stimulation of the work that they did, but because it does actually force you to talk to people, which is an interesting one. For people like me who work from home, you can become extremely isolated.
Yeah, you can. But then you have your beautiful doggy, and your beautiful doggy allows you to go to a park. And if you let your, yes, she's so cute. If you are open to it, a dog is a great way to socialize because everybody comments on each other's dogs. You have to watch your dog interact with everybody else. Are they being nice? Are they being kind? What's this owner thinking? It's a very physically and intellectually active, activity that you can do once or twice a day.
Because my dog is not a social dog. My dog only likes one other dog, and therefore we spend most of our time trying to work out how to keep the dog away from other people's dogs. But there you go. Lucky me.
Exercise?
Yes, it's exercise, if nothing else. Yes. Yeah. So from a distance, we have conversations about other people's dogs. Yes, that's true, though. It is nice. So dogs, keeping pets, that's a good thing for your brain as well.
Yeah. There seems to be quite a good link with pet ownership, and it kind of doesn't seem to matter whether it's a dog or a rabbit or a bird or a fish. It seems to be that, for pet ownership and having somebody else to care for older people is really worthwhile. We don't have that same evidence for midlife. I personally would not want to be without a dog because I love it. And I do feel like, even though I feel like an idiot when I'm talking to my dog and have an entire one-way conversation with them, it is someone that I am interacting with, and I have a whole range of emotions, and I am interacting. So it's kind of a nice thing. But I wish my mum had a dog. I think it would be really good for her.
Yes. Oh, yeah, everybody needs a doggy. Other things, are there anything else? I mean, obviously smoking. Smoking's not a good thing.
No, well, smoking's not good for anything, not even one. I wouldn't have even one cigarette. I feel like a bit of an anti-smoking zealot, and possibly because, at 16 I did temporarily smoke for I think about 3 weeks, and there I'm allowed to be a reformed smoker on that basis. But I really think it stinks. But also, it's expensive. It's like really expensive, and there is nothing good in it. It's now antisocial. You're kicked out of every place. Like, it's not a bonding thing anymore to go and have a ciggy with somebody. It's just like isolating and alone. Absolute loser. Let's not do that.
Yeah. Are there other things that we haven't touched on? I can't remember now.
I think it is worth talking about HRT and dementia because I think that study came out, and once again, another stupid round of headlines prompted by a stupid headline in a study, to be honest. And what we need to talk about, I guess, are the forms of HRT that were examined in that particular study, but also that timing hypothesis that we've already talked about with heart disease. So we do know that it does look like if you start taking hormone replacement therapy during menopause transition or in the very early stages of menopause, it seems to be both cardioprotective, but probably also protective of your brain as well. There is something that happens when you have been without estrogen for a particularly long period of time, and then we reintroduce it. That time frame looks like to be about 6 years, at which point it actually flips from being helpful to potentially harmful. And that's why I would urge, I guess, people, I guess everybody who listens to your lives, Fee, is already on the menopause bandwagon and gets what is going on in their body. But I guess we need to help us.
Got those questions right in the thing. I was sitting there's like 80% of people actually got the. I thought these are tricky questions. People are not going to get these right, and they knew too much. They knew too much.
You've just got a very well-educated, I guess, audience. But there are a very large number of our sisters out there who are still terrified of taking HRT. And by the time their fears are alleviated, they now have crossed over to the point where it could now be more harmful than helpful. And that is really, really devastating, I think. And I think as a sisterhood, we owe it to other women to raise awareness around. No one is saying that every single person should be on hormone replacement therapy. That's ridiculous. And we certainly the Americans went too far in that in the 1990s, which is why we got the pushback with the Women's Health Initiative. I completely get that. But if you are having symptoms that are dreadful for you, then we don't want people to then finally go, okay, I'm ready to do this. And we have to say to them, it's too late. You've missed that window of opportunity where you could have gone on HRT and it could have been helpful for you. But now it is harmful. And so we do need to be careful and just raising awareness around it.
Yeah. The other thing out of the study as well was that, as they said themselves, the ones who were more likely to develop dementia had pre-existing conditions of high blood pressure, diabetes, had lower education, were of lower socioeconomic status. There are a whole bunch of things in there that made them far more predisposed, which goes back to exactly what you're talking about in the book, is like dealing with those risk factors, not just
midlife
is the one thing that's going to do it. You've got to do more. And the other thing was that, given that they were on HRT, they probably did have quite severe vasomotor symptoms and other types of symptoms,
which had predisposed them.
Yeah. So it was a study that, as you say, poor headlines and not well analysed by their people themselves, and certainly not showing cause in any way, shape or form.
No, and I think it really hits a very vulnerable group of women, because women in midlife, who are the ones who are most likely to need hormone replacement therapy because of troubling symptoms from their menopause, are the ones who are often caring for their elderly parents or parents-in-law and starting to see dementia up close and personal and being absolutely terrified of it happening to them for good reason. They're also at the most busy time of their lives, often career-wise. Often they've got teenage children who are quite demanding and, often worrying them a lot. They're stressed with their parents, often a lot of them themselves, or it's peak time for divorce. A lot of their girlfriends are really draining them with, stories about their own traumatic marital breakdowns. There is so much happening. This is a group of women who are very, very vulnerable. And this kind of headline it just really picks on the wrong person. That's my real devastation about it, I guess, because it's groups of 20-year-old women. They might be impressionable, but they're not as vulnerable, and they've got time to work through this. Whereas this is, women will throw their HRT in the bin at the very time when they need it the most, and that's really, really sad.
Yeah. Yeah. In terms of HRT and protection of the brain generally, where are we at the moment?
So there are new data sets coming out all the time. What we've got to remember with dementia is that you need very, very, very long studies. Because if I get a group of 80-year-old women, who statistically a large number of them are going to have dementia, and I ask them, what did you used to eat 5 years ago? Or how much sleep did you used to get? That data would be practically unusable. I mean, there would be no way of verifying it. We know that retrospective recollection for what we ate yesterday is appalling, let alone what we did 30 years ago. But if we follow people up for 30 years, you need very large amounts of money to do that. And you need very large trials to achieve what we call statistical significance. In other words, 800 people in a trial will never work. it's got to be tens of thousands, which is why that blood pressure trial where we had, 160,000 women that we followed prospectively, that was so powerful because we had those numbers, 160,000, to say, yes, we can run those numbers, get a statistician to get involved and say it is definitely 120 is the number. To get that with hormone replacement therapy, particularly when the kinds of forms that we're using are changing all the time, is really difficult. So we don't have hard and fast data yet. So what we're using is what we call like proxies. So we're using brain scans to look for early signs that there might be dementia on the way, shrinkage in certain areas of the brain, or less glucose uptake use by certain parts of the brain as a proxy for a risk for dementia. But what we're really circling in on is what we call that timing hypothesis, that if you continue to take estrogen while there's still estrogen in your body, in other words, your estrogen actually it hits its nadir about 2 years after your official menopause. So you actually still got a little, your ovaries are not completely dead and dormant for quite a while after you've gone through menopause. Your ovaries actually continue to produce a little bit, and your lowest ebb is about 2 years after menopause, which is often when your peak hot flushes happen around that time. If we can give you estrogen while you still have some estrogen in your body, and therefore your body has not responded to no estrogen, that appears to be the most protective for both the heart and the brain. I'm Pauline Mackey, who is the American, I guess, guru of everything brain and menopause, spoke at last year's Australasian Menopause Society, and we also had some cardiologists from the US pretty much saying the same thing. It looks like it's all about the timing, and that to continue on. And of course, we would prefer, if we can, for you to have what we call transdermal estrogen, which reduces your risk of clotting, or it doesn't reduce it, but it doesn't increase it, whereas oral estrogen can increase your risk of clotting.
There you go. Is there anything else, or have we covered it, do we think?
Look, there's so much in that book. I think that book is a very dense book, and I was very aware that my sisters are middle-aged women are a very stressed bunch, and I don't want anyone to think that you need to do every single thing in this book or you're toast and your brain is already going to fail. This is an all-you-can-eat buffet. For every change that you make, it'll make a massive difference, and for free, we'll throw a whole lot of less cardiovascular disease. Better mental health is just worth having anyway. I've got tips from amazing experts, the best in the world, and I think it is worth a read. I would say that, wouldn't I? But I do actually think it's a pretty good book, and hopefully,
and that it's dense. It's actually you've written it very well, darling. It's very it's an easy read. It's not a as you say at the beginning, you've got your sciencey bits and whatever, but then it's a very, very easy read.
Yeah, it is an easy read. It's not targeted for other doctors. It's targeted for people who really want to save their own brains and just do and who've hit middle age and gone, you know what, time to get serious, time to shed those kilos, time to not have a whole bottle of wine every single night. Let's do this. We're going to get ourselves healthy. This is kind of a really good book for you. Nice framework, and you can pick whichever ones you want. No stress.
Yeah, brilliant. All right, and people can find it on Amazon, yes?
Yeah, actually, so online, most bookshops, I believe it is selling quite well in the UK at the moment. That is what I have been told with my meeting with my publisher last week.
Oh,
yeah.
Good. Oh, good. No, excellent. All right, my possum. I will leave you there to go on with your evening, and I'm going to. I'm heading off to meet a friend of mine from NASA who is a rocket scientist. So there you go, a blonde-haired female rocket scientist. I love saying that. I'm my friend from NASA who's actually a rocket scientist. So I'm going off to meet her.
Love her too.
Absolutely. That's inspiration for you. Tell your children, yes, you can be a rocket scientist. Absolutely, if you want to be. Brilliant. I will speak to you soon. And everybody, get the book. It's worth a read. And also, if you haven't donated to the Menopause Education Research and Education Fund, do so, because as Dr. GInni says, we need a lot more research. And to do that, we need an awful lot of funds to be able to do it. So there you go. I will speak to you all soon. Take care, and I will end this one here.
Bye.